and then of course working with them on PPE in order to keep residents as well as staff members safe. I'd also like to provide an update on the Procter & Gamble facility. Universal testing is underway at that facility and is expected to continue through Wednesday. The first set of laboratory tests are being tested now. We expect to have the initial batch of results probably tomorrow. And again, the universal testing process remains underway and will take until approximately Wednesday afternoon to completely test all of the full-time staff and contractors associated with that facility. And finally, at the Milestone shelter, there have been a total of 2 residents and 3 staff, which is the same number that has been the same number of cases associated with that facility for the past week. I'd like to next turn to provide an update on some of our overall public health preparedness activities. Let's start with one of the topics, one of the requests that has been perhaps most in high demand across the nation and across the state in recent weeks, which is that for swabs and viral transport media. These swabs and viral transport media are essential elements in making sure that healthcare facilities, clinical providers can actually test people for COVID-19 and send those samples to the Maine CDC lab. Thus far, Maine CDC has distributed 22,635 swabs and 20,229 vials of transport media to facilities across the state. We are continuing to receive shipments of both from the federal government, and as we've talked about, as soon as those supplies come in, they are inventoried and put out on the trucks for delivery ASAP. Even though we've been talking more recently about swabs and viral transport media, our work to distribute PPE has not slowed down. In fact, Maine CDC has now distributed 2,000 orders of PPE. What's equally important is not just the number of orders, but the number of pieces of PPE. As of today, Maine CDC has shipped out 1,351,009 pieces of PPE to healthcare providers across the state. That amounts to about 1 piece of PPE for every single person in the state of Maine. We are not slowing down. Requests continue to come in, and as they come in, we fill them almost immediately and get them out on the trucks for delivery. But as of this morning, I wanted to just take a brief moment to thank the team in public health preparedness. The fact of the matter is, it's not a huge team. It's a collection of individuals who have dedicated their lives to managing PPE, managing requests for it, and getting it out the door as soon as possible. And I'd like to just take a second to acknowledge the work that they've been doing, preparing for this situation for many, many months and years. And now that we are in this situation where we are faced with constant and ever-present needs for PPE, rising to the challenge to get the vital life-saving pieces of equipment out the door. And again, as of this morning, they have now shipped out 1,351,009 pieces of PPE to healthcare facilities across the state, and we don't show any signs of slowing down. I'd like to just provide a quick update on next some of the vital assets that we've been tracking. Overall in Maine right now, there are 397 total ICU beds, 155 of which are available. There are 317 conventional ventilators, 242 of which are available, and there remain available 441 alternative ventilators. At present, right now in the state, there are 52 individuals who are hospitalized currently. 17 are in the intensive care unit and 10 are on ventilators. And finally, before I turn it over to our colleagues for questions, I wanted to provide an update that just came in just a few hours ago. The state of Maine will be receiving another shipment of Remdesivir from the federal government at some point this week. we were told that we would be receiving 4 cases of Remdesivir, again, hopefully in the next coming days. We will follow the same protocol and algorithm that we followed before in distributing that Remdesivir to healthcare providers across the state. Once we have that in our supplies and once it's on the trucks out for delivery, we'll make sure to keep everyone updated on where that stands. So with that, I would like to turn things over to our colleagues in the media. And today's first question goes to Emily Tadlock at WABI.
Hi, Dr. Shah. Thanks so much for taking our questions. My question today for you is, as the head of the state CDC, lots of businesses are reopening today. How comfortable are you with these businesses reopening, and how confident are you that we could keep a resurgence from happening?
Well, Emily, that's a great question. It's something that our team talks a lot about. And what I'll start off by saying is that reopening is not the same as returning to normal. The conditions under which businesses across the state are reopening are, in many instances, quite different from the way that they operated just a few months ago. And in almost all instances, not a return to normal. The way in which businesses have been asked to reopen, have been provided guidelines around reopening, is to reopen in a manner that simultaneously allows resumption of economic activity, but also simultaneously protects public health. And the way in which the guidelines and checklists that help businesses reopen have been constructed is with those twin goals in mind. So for example, when you go out and shop now, for example, my family and I had an errand to run on Saturday, and we noticed that the retail outlet that we went to had plexiglass everywhere. I was actually really curious because of the nature of the store that we were in. And so I asked the manager, tell me everything about this plexiglass. How much did it cost to put up? How hard was it? What's your take on it? And the manager of this facility said, it was really straightforward. Took us not very long to put up. It was plexiglass and PVC, and it's given everyone psychological comfort in working here as well as coming in to shop. So Emily, I think the bottom line is that even though reopening is not the same as returning to normal, the reopening is being done with very close eyes on some of the public health implications so that the reopening can be done safely as well as allow that resumption of economic activity. The next question goes to Don, the Earl of Kerrigan. Don, I see you on the screen. May I ask you to unmute?
Try that. Can you hear me now?
Yep, loud and clear.
All right. My apologies, everyone. More cases in nursing homes, congregate living. What is it that we're not doing, or that those facilities are not doing, or individuals aren't, that we keep having new cases, new outbreaks in these kind of facilities? What is it that needs to happen that isn't?
So, Don, I want to respectfully somewhat disagree with one of the premises or the assumptions in the question, which is that anytime there's an outbreak, I know you didn't say it this way, but when there's an outbreak in any kind of facility, there's evidence that something wasn't done that could have been done. And in some cases that might be the case, but not in all cases. You know, the way I think about outbreaks in facilities like this is it's a little bit like putting a pot of water on the stove and cranking up the heat. We know that eventually bubbles will rise to the surface, but we're not able to predict exactly where in the pot those bubbles will rise to the surface. And outbreaks in nursing homes are somewhat similar to that. What I mean by that is that for one of the things that the public health community has learned nationwide over the past few months is that many of these outbreaks are introduced by visitors, by outsiders into the facility. When you couple that necessity of having folks come into the facility to work with the fact that the individuals who live in these facilities are uniquely vulnerable from a medical perspective, you do have almost the perfect setting for an outbreak to take hold. Now, what I think this really points to is that long-term care facilities, congregate care facilities, are not islands unto themselves. They employ and are staffed by men and women who come in from the community. And when you have areas of community transmission, as we do in a number of counties in Maine, there's still the remote possibility that an individual can come in, not realize they have any symptoms at all, and unfortunately and sadly introduce the virus. That's not through anyone's fault. That's not through anyone's blame. It really is indicative of how quickly the virus can spread and how we know it's likely to spread. That being said, facilities across the state have taken extraordinary measures nowadays to try to limit that. I think about instances in countries that have not taken such extraordinary measures, where you see significantly more outbreaks and sadly significantly more fatalities on a population level because they did take steps to limit community transmission. I'm thinking most notably of Sweden. And so what the bottom line here, Don, is that there is a tight link between measures to reduce community transmission and the subsequent benefit that we see in fewer nursing home cases. To put that even in starker contrast, by wearing a face covering, by maintaining social distancing, you're not just protecting people around you and your family, you might be reducing the likelihood that you could expose a worker in a long-term care facility, and thus you may be indirectly reducing the likelihood of an outbreak at a long-term care facility by doing something as simple as putting a mask on yourself. So there's certainly more to do in terms of making sure that facilities stay up to date on the latest infection control practice, but there is this tight linkage between what's going on in a community and how that can be transferred into a long-term care facility.
And I have one other question, if I might ask it, please.
Yeah.
The cruise ship that wants to come into Eastport, and I believe the governor has given her approval to that, has the CDC basically agreed that it's safe for that to come in? And will the CDC insist on any testing of the people on board before it docks in Eastport?
So we are reviewing the plans that the cruise ship company has put forth. And we're looking at really two things. The first is, what is their plan in the event that an individual crew member becomes ill? Do they have a way to transport an individual crew member via EMS? And have they established a relationship with a close by hospital who has said they will take those patients? Don, you raise a separate question around testing. Testing is really effective. But what we know now is what's better than testing, or at least as good, is a mandatory 14-day quarantine. So one of our principles is that as we think about testing, yes or no, what's absolutely a principle of ours is ensuring that no single crew member who might be on that ship is allowed on shore until they have gone 14 days without showing any symptoms whatsoever. When someone has gone those 14 days without showing even the slightest bit of symptoms, the likelihood that they've got COVID-19 is vanishingly small. So we're aware of the request, we're reviewing the plans, and those discussions are very much underway.
Thank you.
You bet. Going to turn next to Megan over at WMTW.
Thank you for taking my question, Dr. Shah. This one refers to the protests that we've seen across the country, really, and here in Portland and other cities across Maine. Are you concerned with the protests in the past couple of days and the subsequent days to come that this will increase the spread of coronavirus? And if someone is willing or wants to take part in a peaceful protest or a protest, do you have any recommendations for them in terms of how they can protect themselves?
Megan, thank you for that question. I want to say this directly to everybody who's watching, and I say this with the utmost and most heartfelt sincerity. If you are going to be outside in any form, and you're not able to maintain physical distancing, please wear a face covering. If you can maintain physical distancing, I would still ask that you wear a face covering. There are an increasing amount of data almost daily that come out suggesting that the possibility of transmitting coronavirus when you don't yet have symptoms is playing a bigger and bigger role in the ongoing outbreak that we're seeing. And so when I say this, I really, truly do mean it. I want everyone to take the most care they can to stay healthy and protect others when they're outside. And in this particular setting, I ask when you're outside in any setting, be it a congregate one or just with a couple of people, please wear a face mask, and where possible, try to maintain at least 6 feet of space between you and the next person. I'm going to turn over to Eric Russell at the Press Herald.
Thank you, Dr. Shah, for your time. I have 2 questions, if I could. Do we have the capacity right now to test all congregate care workers regularly? So it seems like the workers are the ones who are bringing in, very likely bringing in the virus. And I wonder if there's a way to test them all. Do we have that capacity now? And is that something we might be getting towards soon?
So the bottom line answer to the question of, is that where we're going? The answer there is it's under extremely active discussion. You are correct in that my thinking on this is that although testing is greatly, the capacity for testing is significantly greater than when it was just a few weeks ago, we now have to think about where we should start deploying that increased capacity. And one of the highest value groups in terms of, to Don's earlier question about reducing potential outbreaks, would be more widespread testing of staff who work in any kind of congregate setting, be that a long-term care facility or other types of settings. Capacity is partly a function of how quickly we would have liked to have that done. We wanted it all done on one day. That may not be something we could do in one day. But if we staged and phased the process over a number of days, and then we also looked to other laboratories across the state to assist in that, that's more of a viable option. And what I can tell you, Eric, is there are very active discussions underway right now about how to take those ideas and then operationalize them. To provide a quick glimpse, the numbers of individuals just at long-term care facilities of staff that we might be talking about ranges anywhere from 10 up to 15,000. So making sure that we not only have the laboratory capacity, but also just the operational capacity to conduct the swabs on those individuals and return results in a reliable manner, that's one phase of it. The other piece we're making sure we think through, Eric, is what to do when there's a positive. Certainly when an individual is positive, there are implications for that employee in terms of their ability to work at that facility while they're recovering. So we've got to think through the chess game of how we address staffing shortages before we go down that path, not while we're in the middle of it. Folks have heard me use that analogy before, but before I make the first move on the chessboard, I like to think through all the way to the end game, or at least as far as possible, because I don't want to be solving an emergency that we could have thought through, like the staffing piece, before we went down that road. So those discussions are underway very actively right now. Once we have all the pieces on the board in place, then we'll be talking about it a lot more deliberately.
I just had one other follow-up question on testing. Now that we've seen an increase in testing over the last couple of weeks with that increased capacity, what conclusions have you been able to draw in terms of the daily case numbers, the negativity rate? Are you any closer to some conclusions about where we might be headed?
So let me, Eric, let me kind of just provide a sense of where we are and then where we're headed. Where we are right now is that our cumulative positivity rate for PCR tests, just the ones that demonstrate an active infection, remain at about 5.1%. By contrast, those nationally remain at about 11%, and in our neighboring states, some are much higher than even 11%. So relative to other states, that gives us a sense that the net that we are casting is a good one. I've said publicly that I think we've got more work ahead of us to get that positivity rate down even lower. And so we've still got more to do in terms of expanded testing. One quick side note on the positivity rate. I've said before that the reason it's important is that it tells us how wide of the network casting. I want to put a little bit more of a finer point on that and connect it with something that we chatted about with Don a few minutes ago. When you're looking at a disease where so much of the transmission and so many of the outbreaks are driven by individuals who are asymptomatic, diagnosing those asymptomatic folks and working with them so that they can be quarantined and isolated safely before they infect others is critical. And that's why that positivity rate, driving it as low as possible, is so important. It's partly so that it means we're testing the right groups of people, but it also suggests that if we get it low enough, we're capturing not just symptomatic people, but asymptomatic people as well. So we can start working with those asymptomatic folks to prevent the kinds of outbreaks we were just talking about. So now that's where we are. Now, where does it mean we're going? Well, one is what I noted. It means we've got more to do in terms of expanded testing. We would like to be able to offer and get people more access to testing. For example, if they are a close contact of a confirmed case. That's one example. We'd also like to expand testing to different types of facilities as well. For example, the staff that you mentioned a moment ago. But I think where it tells us we're going is that we're on the right road, but that we just haven't reached our destination yet. And we've got more to do. So we're getting to where we've been wanting to go. We're just not there yet.
Thank you, Dr. Shah.
You bet, Eric. I'm going to turn next to Amy Brown at WERU.
Thank you, Dr. Shah. In addition to asking about health and where people have been traveling at screenings for COVID, should employers or other people doing these health screenings also be asking about whether or not people are following the distancing guidelines and wearing face protection in the community as part of a regular health screening?
Amy, just to make sure I answer your question accurately and fully, when you're talking about health screenings, are you talking about normal check-ins with your physician, or I just want to make sure I know what you're referring to specifically.
Yeah, well, the places where they're doing the screenings before you're admitted. Like, for instance, at a doctor's appointment the other day, they ask if you've traveled to southern Maine, they check for fever, they ask, if you've been exposed to anybody. Among those questions, should they be asking about whether or not people are practicing these guidelines that you've put out for safety while on their own time?
Got it. Yeah, I don't have a strong recommendation there. All of those questions are designed to assess someone's overall risk. So if someone came into the office that you noted and said, yeah, of course I've been in southern Maine, or yeah, I've been in Boston and I definitely have not quarantined, and I definitely have a fever today, and man, I've got this cough that I've had for the past day, and I've got a lot of other symptoms, that tells you one thing about their risk level. But if they answer no to all the other, if they answered no to all of those, it tells you something else about their risk level. Individual providers may ask different types of questions, but the key ones are more about where you've been and whether you, for example, if you've been out of state, whether you abided the 14 days or whether you've got any symptoms today. But certainly if a provider wanted to add in additional questions, do you regularly practice social distancing? Do you regularly wear a face covering when you're out of doors? That can only help provide more data to the healthcare staff. And so in that respect, I don't disagree. Knowing someone's overall health habits in any situation, whether it's COVID-19 or any other type of infectious disease is really critical to helping clinicians get a sense of what's going on. So if a physician's office wanted to build those in, by all means, it can only add to the data that they've got at their disposal to help really gauge what might be going on with the patient.
Thank you. And if I could ask a follow-up question from one of our listeners. We've been asked to ask you if the virus can spread in water. The CDC's website talks specifically about chlorinated things like pools and water parks, but fresh water, seawater, should people be concerned?
Based on what we know right now, Amy, the virus is almost overwhelmingly transmitted by inhalation of particles of respiratory droplets that have the virus in it. So it's not the water per se that might spread it. However, if someone were in very close proximity to someone with COVID-19, it doesn't really matter what the setting would be. They could be in a swimming pool, they could be on a park bench together. If they happen to be in very close proximity, there's still that possibility of transmission of COVID-19. Being in chlorinated water doesn't provide a security blanket. In the same way, being in unchlorinated fresh water doesn't mean it's more risky. It's really about the physical distance that any two people might be in. And I'll say another thing. As I think about the overall risk as we're all getting back outside more, it's kind of crazy, but when we started thinking about COVID-19, there was ice and snow on the ground. And when we first started these briefings, the biggest risk that a lot of us were worried about was whether our snow tires were going to be able to get us home. We're now into the beginnings of a beautiful summer, and we're all working and ready to get outside more, which means inevitably that we will be interacting with others more. It might be at water parks, it might be at pools, it might be at the lake. The things that I think about in helping folks gauge the overall risk of any activity really come down to two things: the duration of the activity and the density of the individuals who are going to be involved. So you might be in a pool, but if it's a packed pool and you're going to be in the pool for hours, that's a lot different from swimming by yourself in a lake with no one else around. So I ask everyone to think about the duration of the activity and the density of people that are going to be around them. We're going to turn next to Steve Betts at the Courier-Gazette.
Yes, thank you, Dr. Shah. Have you got any more updated numbers on the number of out-of-state residents who have tested positive or their tests have turned out positive in Maine?
Steve, I haven't looked at those numbers. Perhaps my staff has, and I can get them for you. But it is, I think the overall percentage is where it has been before, which is to say pretty small. There are a few folks who have been out-of-state residents who have tested positive in Maine. The bulk of them are New Hampshire residents who seek healthcare in Maine. There are similarly Maine residents who have tested positive in other states, but overall the numbers have been quite small.
Thank you.
We're going to turn next to Susan Sharon from Maine Public.
Hi, Dr. Shah. Thank you so much. Two questions. One, how close is the state to meeting its testing capacity, which I believe is 1,000 a day? And secondly, where do things stand for sentinel surveillance?
Great. So let me, Susan, I'll take your first question in the following way. The US CDC has recommended that states test approximately 2% of their population every month. Maine has far exceeded that recommended threshold for quite some time now. We have been regularly testing at least 9,000 people per week, or say 36,000 people per month, statewide. That's not just at Maine CDC, that's for all laboratories. So just in terms of what the US CDC recommends states do, we have far exceeded that baseline recommendation already, and we intend to continue exceeding it. Now, within the Maine CDC laboratory, testing volume varies significantly day by day. So just to provide a few numbers around that, for a few days the week before last, we were doing regularly 1,000 tests per day. In fact, I think our one-day maximum was 1,031 tests in one day. The numbers fluctuate quite significantly based on what healthcare providers send to us. But to provide a little bit of a sense around that, last Thursday, we received 564 tests. Last Friday, 914 tests. And then, so it does vary. Some days we are right at that 1,000 mark. Some days we're in the 600 to 700 mark. Last Wednesday, we received about 700. So it varies day by day. That's the same for any laboratory. We see nationwide very strong day of week effects. And some days we're right at 1,000. Some days we're at 600, 700. And then your second question, I'm sorry.
About sentinel surveillance.
Got it. So sentinel surveillance, we are working to set up sentinel surveillance in a couple of different ways. One way will be via what we're calling swab and send sites. So individuals who are just generally concerned about their exposure to coronavirus could drive up to a site, get a swab, and have it sent to the state laboratory. That is, in effect, a way of undertaking sentinel surveillance. The other way that we're looking at sentinel surveillance is to work with the laboratories that we already work with for influenza testing, to offer COVID-19 sentinel testing to them already. That's underway and is one of the things that we're working on. But I should also note, just to be sure, Susan, the other way in which we undertake sentinel view of what's going on is through what's called the syndromic system. This is a network of providers and emergency rooms and urgent cares who report to Maine CDC without any patient names the types of symptoms that folks are coming in for. And we've created queries. One is a very broad one, and the other is a very specific one for COVID-19 that give us a sense of what types of symptoms people have out there. All of that information is on our website, and folks can take a look at just what types of symptoms are out there in the community. We're hoping to couple that in the very near future with the testing as well, especially now that we've got this added capacity. Next question is for Isha at the BDN. Isha, could I turn to you next? Sorry, Isha, can't hear you. I can see you, but I can't hear you. We'll come right back to you. Yep. We're going to go to Brad Rogers at GME next.
Hi, Dr. Shah. I have a couple of questions for you. First, I was just curious about Remdesivir. Have you gotten any feedback from any of the doctors on how it's working?
Yep. So we've gotten some feedback, or some of our medical officers have gotten feedback. It's been used in a number of patients across the state. I think the data in Maine mirror the data that we've seen nationwide, which is that it seems to help reduce the length of hospital stay, but not so much, unfortunately, with respect to the individuals who pass away. Nationwide, that's been the experience, and new data seem to come out every week on not just the value of Remdesivir, but the patients in whom it might provide the greatest value. Big study last week in the New England Journal looking at whether it should be given for 5 days versus 10 days. We try to share those data with clinicians across the state so that as they are making their clinical choices on which patients to use Remdesivir, they've got the latest data.
So just to follow up on that real quick. So do you recommend it for patients who maybe aren't quite as severe, using those patients?
You know, the medical jury is still out on that one. One thing I want to note, Brad, Maine CDC does not control or recommend who should get Remdesivir. The Remdesivir that we receive from the federal government, that is fundamentally and ultimately a decision for the healthcare provider at the bedside. Maine CDC does not We don't stand in that decision at all, fundamentally up to the treating physician. But we do want to make sure we're equipping physicians out there with the latest data. And the medical, the medical scientific community has still not really fully developed a good set of data on whether remdesivir should be used for the very sickest of the patients or whether it ought to be used a bit earlier on. I had the privilege of being on a call last Friday, just a couple of days ago, with the chief medical officer of a group called ASPR, the Assistant Secretary of Preparedness and Response at the federal government, a gentleman named Dr. John Redd, a highly respected clinician. And we put the same question to him, 72 hours ago, and he sort of said that the data are not all in yet.
Okay, and then I have a quick question from a viewer. They would like to know, what about playgrounds? Do you know when it's going to be safe for playgrounds to reopen, and are they safe?
So, Brad, playgrounds are in the same vein as we were talking about with all outdoor activities. I would urge parents to think about the exact same figures, the same two axes when it comes to playgrounds as well. What's the duration at the playground, and how dense is it? Because a playground where there's only your child playing is a radically different one from a packed playground with dozens and dozens of children and adults. All that being said, thankfully, most of the data that we have around children suggests that they are not nearly so affected by COVID-19 as are adults. But what we don't yet have a great handle on is whether children could pass the virus back on to their parents or grandparents. So playgrounds themselves may pose less risk to children, but we've got this open scientific question about what children may transmit. And so for that same reason, I recommend thinking about the same two questions. What's the duration at the playground, and how dense is the playground in terms of the number of children there?
Okay, thank you.
You bet, Brad. I'm going to turn back to Isha now.
Can you hear me now?
Loud and clear. Go ahead.
Thank you. Sorry about that technical difficulty. I have two questions for you today. The first one is about President Trump's reported visit to Maine. I was wondering if you can tell me what challenges do you think his visit will create for the state? And the second one is about reopening, but I'll let you answer that one first.
Yep. I've been made aware by the governor's office that the president is intending a visit here. I haven't been provided any further details, so I can't really comment. I don't have any further thoughts on any challenges that his visit may prevent or challenges his visit may introduce or may pose.
Okay, thank you. And my second question is about school reopenings. Do you know when Maine CDC and DOE will release guidelines for reopening of schools, and how those guidelines will kind of help school districts balance reopening safely with added precautionary measures and prioritizing in-person education, all while considering school budget challenges?
So you put your fingers right on it, which is to say there are active discussions going on trying to balance those two exact things. The Maine Department of Education is taking the lead on those. And so Isha, sort of similarly, I would recommend that you touch base with them in terms of what their timeline is. But we've been actively engaged with them and are trying to balance the things that you just noted, which is child safety, the value of in-classroom education, and of course, recognizing that everyone's budgets are strained right now. What type of controls might schools need to introduce in order to maximize child safety? Those are the exact considerations we're thinking about and how we balance those. It may look different in different parts of the state for different schools, but as to the timeline itself, if for complete accuracy, I think DOE would be in the best position to give you more answers there.
Just a quick follow-up on that. How much do you think the US CDC reopening guidelines will factor into your guidelines?
I think they are very helpful for setting the parameters, the rules of the road. The question, I think, will be how those are operationalized and whether they will be operationalized the same way in every district. I mean, I think for everyone, it's pretty plain now that the nature of the outbreak, the epidemic across the United States has been dramatically different. Maine has been radically different from Manhattan. And even within the state of Maine, the complexion of the outbreak has been different. Cumberland County has looked much different from Aroostook County. And so in keeping with that, the question then is, will school reopening follow those same differences and look different across the state? The CDC guidelines provide great parameters, the rules of the road, but operationalizing them and allowing for that different local control, that's really where the discussion is right now.
Thank you.
You bet. Well, thank you for all the questions, everyone, today. I also would like to take a moment to thank everyone for tuning in this afternoon. We will continue to make sure we are providing updates as often as we can. And so I'd like to thank everyone for taking some time out of their afternoon to join us. I hope everyone has a lovely afternoon. And as always, please take care, be kind to one another. These are, of course, challenging times for all of us across a variety of spectra. Please take care and be kind to one another. We'll talk tomorrow.